Good morning. So I have worked with refugee and immigrant communities for my entire career in a variety of ways. Most relevant, I think, for the meeting today is that I've been the medical director for Massachusetts' statewide health screening program for refugees entering the country from overseas for about 20 years now. And I've also practiced primary care pediatrics, typically in settings with large immigrant communities. Currently, I have taken on a administrative position, so my clinical care in the past 6 months or so has been much more limited. But prior to where I'm working now, I was with an organization called Cambridge Health Alliance in Cambridge, Massachusetts, where I probably had patients from around 50 countries, at least from around the world, from a variety of socioeconomic and ethnic backgrounds.
Paul, can you tell us a little bit about, just define a refugee for us, and tell us about the kind of work that people do with refugees?
Sure. I mean, refugees, I was saying to Alicia just before we started, have a very defined regulatory system in the U.S. As a visa category with things like political asylum and temporary protected status, victims of trafficking, and some other. So my work with the Department of Public Health is specifically for those people who hold visa holders who are in these eligible categories, which also has included Cuban and Haitian entrants, and some others that come and go over the years, like Amerasians coming out of the conflicts in Southeast Asia, were a specific category unto themselves. So the services in terms of health that refugees are eligible for starts overseas with a health screening program for U.S.-bound refugees, which the CDC oversees and the International Organization for Migration implements for the most part. And once they come to the U.S., most states nowadays have some kind of a defined public health system for conducting health screening here in the U.S. Other services specific to resettlement, such as housing, English language instruction, job placement, those are typically provided by community organizations, and there's a variety of networks around the country who provide these services. Some of the names will be obvious and familiar, like Catholic Charities. Others maybe less so, but groups that call themselves International Institute of and plug in the city or region. The International Rescue Committee, the Lutheran Immigrant Refugee Services. At least in New England, they've changed their name to something that has nothing to do with their mission and is one of these made-up words, so I can't remember what they call themselves now. But there's HIAS, a Jewish group, and some others. There's an African, the Ethiopian Community, ECDC. I'm forgetting what the acronym stands for, but it starts with Ethiopian, and they largely service African refugees.
So refugees are a defined category with access to health systems.
Yes,
health services,
that's the most important part.
And ongoing health care.
Right. So definitely yes to the former, maybe for the latter, in that the supports that refugees get end very, very quickly. The financial supports end within about 8 months. At least in Massachusetts and now elsewhere in the country, the automatic eligibility for Medicaid used to end at 8 months, but then it was extended in states that have done healthcare reform to 1 year. Refugees also were exempt from the 1998 welfare reform restrictions, and so they are not subject to that 10-year work requirement that other documented immigrant classes will need to meet for public benefits for the most part. So yes, and when you have a robust health screening system like we do in Massachusetts, our system is provided through mostly federally qualified community health centers, which are then capable of providing continuity of care for primary care. The screening itself is a public health process, so it's not being done in the capacity of primary care, but we use that as a way to facilitate it. So at least in Massachusetts and some other states that have a well-organized system, it does provide an excellent bridge for primary care. But then, depending on what state you're in, the vagaries of health insurance come into play for those who don't meet the typical categorical eligibility requirements for Medicaid. So, for example, the example I always cite were the Lost Boys of Sudan, a group that I did a lot of research with a decade ago. Many of these young men were, healthy single males over age 18, and so after their immediate eligibility period ended, this was before even Massachusetts had implemented health care reform a decade ago, they lost their health insurance, and that effectively shut them out from care, even though they were refugees here in the country with proper documentation.
Thank you. Mr. Caballero, tell us a little bit about APCHO and the sort of work that you do, the populations you serve.
Thank you, and good morning. Before I get started, though, I just wanted to really acknowledge and express my appreciation for having this meeting in Oakland. I often look for all your reports, but I only get it through the internet, and having an opportunity to participate in the discussion you all is exciting for me. And I also am excited to see community groups being able to participate and engage as well. So again, thank you very much. As noted, my name is Jeff Caballero, and the Association of Asian Pacific Community Health Organizations, or APCHO for short, is an organization that is almost 30 years old now. It is a national association representing community-based organizations that serve predominantly Asian Americans, Native Hawaiians, and Pacific Islanders. We have 35 members across the United States, but literally it's in 12 states across the country. And 30 of those 35 organizations are federally qualified health centers. For many of you who are familiar with FQHCs or community health centers, they are the safety net, and particularly for the Asian American and Pacific Islander population. Just give you some quick demographics. 75% of all of our patients are within 100% of poverty. 92% of our patients are within 200% of poverty. Many of the APCHO health centers serve predominantly 75% average Asian Americans or Pacific Islander populations, and the balance is across the other racial ethnic groups. Some of our health centers serve up to 98% limited English proficient folks. Literally monolingual or bilingual Chinese in 98% of the patient population. But we do also have a number of health centers that provide services in 14 languages simultaneously, like the one here in Oakland's Asian Health Services, or 42 languages simultaneously in the Seattle-King County area. My work predominantly is to do advocacy on behalf of these community health centers to try to elevate the health disparities, promote cultural competency and language access resources. In the last 3 years, I think I just wanted to focus a little bit on areas that you might be interested in. The last 3 years, APCHO has partnered with the Asian American Health Forum and another Action for Health Justice, a network of national and 70 community-based organizations across the country in 22 different states to help in the enrollment process. And over the last 4 years of enrollment, it is 4 years, right? Yeah, 4 years of enrollment, we've touched around 1 million lives and helped enroll folks in more than a dozen different languages. So there could be, we could have some interesting discussions around that if that's an area of interest of yours. And I also have another colleague from the Health Forum here who can also expand on my answers if I don't have your answer. But most recently, I just have to acknowledge that our biggest and perhaps most disturbing work in the last few weeks has been how busy we have been in responding to the anti-immigrant fears in our community. and not just at the community level, but particularly many of the misperceptions and factual perceptions about the federal policies and executive orders that the community is perceiving to be after them. So we have spent significant resources nationally and with many other organizations responding to these efforts. In terms of opportunities that I really want to be able to help elevate, we've been involved with a number of national partners, including the Oregon Primary Care Association, and I understand you're speaking with her tomorrow as well, on a social determinant of health tool that, along with the National Association of Community Health Centers. We pilot tested it in various health center networks across the country over the last 3 years, and made an effort to be able to integrate this needs assessment social determinant tool into the electronic health record, so that the organization can do patient level all the way up to, once they start aggregating it with other health centers, up to city, state, and perhaps, as we hope, national level assessment of our patients and in community served.
Thank you. I want to hear more about that. Paul, did you have a question or for later? For later. Terrific. Mr. Perea, tell us a little bit about the work you do and the biggest challenges that you see in the in the Fresno and Central Valley area.
Okay, and thank you. And thank you for having me here today. Kind of go in a circle here, and just to give you some context of some of the comments I'll be making. But first, I want to acknowledge Hugo Morales. He's in the back, Fresno man. He sat on the first 5 board with me up until last December, from my perspective, and he's also a trustee on the CSU system, California. So welcome. Good to see you, Hugo. But any other elected officials here or former elected officials here? Okay, so I think I can bring a context to you that I'd like you to think about as we're going through this day, because as the gentleman said in the introduction, they started planning for this a year ago, and a lot has happened in the past year. And I think all the great work that you do, if we don't ramp up the political component of what we are doing, we're going to be in trouble. And I think we need to think about how we mesh that with the good work we're doing, with how we have to have people in those seats that are making the right decisions that help everybody that needs help in our cities, our counties, our country. But I'll go back about 24 years or so. When my son was 19, I was just elected to the city council, and he told me, "Dad," he goes, "you remind me of Walter Mitty," because at the time he was 19. I offered him to volunteer in my city council office, and he was kind of, 19-year-old kids are, you live your life, I'll live mine, that kind of thing. I said, okay, fine. But, he said, he goes, you've taught at the university. He goes, you've been a police officer, you've been a school board member, now you're a city councilman, you went to USC, you got your master's in healthcare, you've been an HR director for 30 years, and then in the end, he kind of said, what do you want to do the rest of your life, And I go, well, son, as parents, we teach our kids, we educate you so that you can have that key to open whatever door you want. And I go, and that's what I have done. And I only tell you that story because I think all of those experiences have prepared me for really being here today and then where I'm going to be in the future. Because if you would have told me 20 years ago that I was going to be in politics, I would have said you were crazy. But I just happened to have stumbled into that opportunity. But once I found that public policy, where, like I say, I just left the County Board of Supervisors after 12 years. But when you think about 5 people every Tuesday pushing the button on $2.7 billion in Fresno County, that's where the power's at. That's when you turn public policy into implementation by allocating those dollars. And if you don't have the right 5 people in those seats pushing those buttons, you're going to have different choices. So when I was in human resources, I was an HR director at Valley Medical Center, which was a public hospital in Fresno. And a lot of the UCSF interns would come through our doors. We call them our baby docs. And I think that's only because we were getting older, and they just kept looking younger. But But, you know, so I had a real opportunity to see firsthand not just how the healthcare providers worked and what their challenges were, but also the clients that were coming through those doors every day and the impacts that they had. And I think as I moved forward in my political career, then I came onto the Board of Supervisors where I did have the opportunity now to actually impact those populations. I could see it from very different perspectives. And I can tell you, I go back to that 19-year-old son. You know, he ended up going on to the state legislature and served up until a few years ago. And this is where, you know, and I tie it back to the political activism that I think we have to connect to everything that we do every day, in that we had an issue in Fresno County when the Affordable Care Act came into play. We had a contract once we basically privatized our healthcare system way before I came onto the Board of Supervisors. There was a nice arrangement between us and our provider where we paid them around $20 million to provide healthcare for everybody, including the undocumented. Well, when we did the transition with the ACA, we created a gap. And that gap, as you know, folks are by law entitled, regardless of status, entitled to health care, emergency health care. And then we have FCAs that provide health care, primary care to some degree at the back end. But the gap we created was the specialty care. And so we knew it was a big gap, and as many of you know, the challenges that we have is we can't completely identify who our undocumented population is because there's no real statistics. So, but we knew we had a big number, and we do have a big number, not just in Fresno County, but the Valley. But the way we handled it was this way. We had a $5 million opportunity from the state that we either need to pay money back or we could use it in a different way. Of course, as 5 elected folks, some wanted to hire more public safety, some wanted to fix more roads, and I wanted to deal with that healthcare gap. So you can imagine the debate that we had for over a year in trying to move that money. Well, in the end, we convinced our local state legislature, who happened to be my son, that we needed legislation that either we spend that money on healthcare for the undocs or it goes back to the state and there are no other choices. Well, that legislation did pass the state legislature, so now we were down in our local jurisdiction with just one option, right? Send the money back or use it for health care. Well, if you could believe that, that was about a 6-month debate because there were some folks who just didn't want to do that for ideological reasons. But at the end of the day, when our board composition did change, the board majority did change, and it did pass on a 3-2 vote, and we created that opportunity for that specialty care gap to be filled. So not to say it was the long-term solution, because obviously it's a Band-Aid. So one day that money will run out. But I'll just bring it back to the many challenges that we have in the populations we deal with, in your question, and why, I will continue moving forward. Even though I'm not in an elected office, I will still be involved politically. That's why we always have to be working together and keeping in the back of our minds that do the good work that you do, but connect into your political connections within your communities, because, when you don't connect those two dots, we're going to be fighting a rearguard action from here on forward.
Thank you so much. So one of the things that we wanted to bring out in this panel, I think, has come out, which is that these groups of these patient populations are defined very differently legally, and because of their different legal status, have different access to health care and differential status with respect to health care. And I think that those obviously are mainly political definitions, and I thank you for bringing out the work that has happened in California to try to make available health care to the undocumented as well as to documented immigrants. Now, that said, all of these groups also, however different their legal status may be, do face some similar challenges in dealing with a healthcare system that may be foreign to them. And I realize that that if I'm not mistaken, the two of you are not clinicians and don't know that challenge in that way. But I'm wondering how that has shaped your thinking in terms of what you think are the biggest challenges in providing health care to these groups. Paul?
There we go. In my capacity in public health, when I'm studying refugees, I like to emphasize that there are a lot of similarities with other immigrant groups. For example, when you look at refugees from sub-Saharan Africa, they're mostly from the Great Lakes region and the Horn of Africa, at least more recently. But the largest number of migrants from Africa are Nigerians, and followed often by those from Uganda. They typically don't get refugee status. They come with other legal statuses typically, or sometimes without. And the similarities that they face in terms of health care can be pretty similar, and it's actually how I got interested in health literacy when we had some ostensibly English-speaking refugee populations from West Africa, and we realized that their English proficiency was actually quite low. The expectations on them to be literate and health literate in this context also were quite high. And in fact, in many of the cases, like in those from Sierra Leone, their English was a second language. They had a local indigenous language, and then even the English was sort of a Creole type of English. And so they faced a lot of challenges, and there are lessons that are offered from looking at refugees that are directly relevant. And then some of the challenges that they face in the clinic setting, when I'm seeing them as patients, refugees are no different from anybody else. It really doesn't matter what their status is. They still have the same cultural issues, the same language and literacy issues, and most importantly, the expectations and knowledge level is going to be different. And these kinds of barriers are pretty typical across the spectrum of who immigrants or migrants are in the U.S. For refugees, maybe things are a little easier because at least they know they have health insurance, and that's generally not going to be a question, although it might again be a question soon, depending on how things play out in the next few months. So I think that refugees offer an interesting window into the world of the larger world of immigrants, in that we can look at some of their health issues a little more closely, perhaps because of their accessibility to the system, yet they also face a lot of the same issues. And I think culture and expectations is an important one that probably is universal regardless of literacy level. And then also the need for community supports with smaller populations that don't come into larger, more well-established communities is something clearly that we saw in our study of the Somali community in Massachusetts, that they really relied on the social networks and the community supports. And in fact, it's really contradictory with something we're taught in clinical medicine, which is not to allow friends and families to do interpretation. And there's good reasons for that, but in fact, in the Somali community, we really came out of our study with the conclusion that everything was a muddle and very complex. But in fact, one of the things we were pretty sure about was that it was community support, social capital, we called it, which is what facilitated the Somalis to getting the services they needed. And I'm going to guess that that's something that's a common feature across a lot of immigrant communities.
It's not coming on at all. As I noted, most of our members are federally qualified health centers, and for those of you who don't know, FQHCs are by law required to provide care to anybody regardless of ability to pay. And in fact, for many years since 1996, many of our health centers actually go out of their way to make sure that they don't ask for either foreign-born or country of origin. And they avoid trying to put that into their records. But they do provide a host of services, particularly eligibility, counseling, and enrollment support to their patients. But we have to be very careful about not being able to keep records of some of that information in their charts. It's really funny. I just think well, it's not funny. It's ironic in that we've actually spent a good amount of discussions in the last couple of weeks with regards to the health records that many of our organizations have, and particularly in relationship to the ICE raids that have been occurring in different parts of the country, and we actually have examples of how our health center has been affected by that. But our community organizations are asking, what kind of legal protections do they have in trying to ensure that these records are not made available to ICE enforcement agents, and based on the best legal counsel that we've received thus far is that there are some protections for the health records, but if they come with a subpoena, then you have no choice but to provide. And so there has been a number of discussions among some groups about, systematic, disenrollment programs, so to help make sure that folks are no longer in the records and in the files, so that it can't be used by custom agents to find people in our community. And it's just been really troubling to think about safety net organizations having to worry about disenrolling and then trying to figure out ways of outreaching to their communities without creating more panic, but helping them feel secure about what they can do to protect their families and ensure their safety. But aside, that's just a little of current activities that's been keeping us in our communities preoccupied. But what I wanted to perhaps spend a little more time with is that with regards to many of the cultural and language barriers, many of our health centers have a systematic way of providing a host of what we call our care enabling services, and these are non-clinical services that many of our health centers provide. And as I noted, it includes like eligibility counseling, enrollment support, case management within the facility, case management for referrals. There's a host of them, including transportation services and so forth, to help overcome many of these cultural and language barriers. In fact, APCHO has been working for the last 12 years to try to standardize the collection and categorization of these services and the relevance to the patient outcomes of our in our community, and which is what helped us prepare for the development of the social determinant needs assessment tool that we are now have been trying to implement into the last 3 years into the health center networks, because for so long these enabling services, we've been using them as proxies for what the social determinants our communities were finding in their service areas, instead of actually asking for the social determinants themselves. But now with this new tool, we are not only finding out what the social determinant factors are actually our patients are coming in with, and what enabling services the health center has been providing to address those, to help them increase the impact or the effectiveness of the clinical services, and therefore improve outcomes. And we are also trying to demonstrate that with that combination of monitoring and quality improvement, that we can help reduce total overall cost of care.
Okay, I think a major difference in the refugee population and the undocumented population is that one, at least on paper, legally, can get services. They have access to services. The other group doesn't. And I know, and that may be a big generalization, so some of you have much more health care expertise than I, but at least that's what I have seen in Fresno County. Where I see, though, the way they're looked at the same is there's a lot of folks who don't want to give either of them care, regardless of the reason, because of the fact that, quote, it's our tax dollars, or we don't want to provide help to these folks. And that's what I have seen and heard more of. But having said that, I mean, I know in Fresno County, I know we talk, when we think healthcare, we talk about, going to the doctor and, going to the clinics for different services. But as we all know, there's public health, there's mental health, there's community health, there's different aspects. And I know in the expenditure of our Mental Health Services Act dollars in Fresno County, in the last few years, we've had a lot of discussion about cultural competence, about how do we deal with the differences in the Hmong community, versus the Hispanic community, versus we have growing populations of Ukrainians in our area too. So how do you deal with it? And again, one of those big debates that we have as a political body, but we move forward and hire shamans and different folks with different religious or cultural perspectives to be a part of the health or medical teams to help provide service to these folks. Community gardens, some say, well, what does that have to do with mental health? Well, it does. It helps. So I think there's a lot of good things in spite of what's happening that are going on, but it's just a matter of how do we keep these things moving forward, keep what we have and gain and not lose ground. So, I think as a supervisor, when we would meet with our community groups, what we found is when we had community groups that were engaged back with us, and when they could fill the rooms, at times to help, bring across their points and what their needs were, it helped us, that we're trying to help shape their end goal, help get the job done. So, it's a lot of, I think, community engagement. It's understanding the issues, having the electeds that can relate to, what's in front of you and what the needs are. And I guess the last thing I'll say, just in terms of challenges, when I look at my county, and don't get me wrong, I love my county. It's a great county. But, when we get into the debates of healthcare and who should get it and who shouldn't, and then you get into all the emotional part of it, I always try to put it in a political context in my county because, it's interesting. The biggest economy in Fresno County, it's about a $7 billion economy, is agriculture. And now even our ag community, because there's such a labor shortage, they now officially admit that 90% of their workforce is undocumented. I mean, if you think about it, if the Silicon Valley, if 90% of their workforce is undocumented, you say, what's going on here? So what I tell people is walk away from the emotional argument. Just look at it from the basic, simple economics, supply and demand. If you apply those principles, you'll see why we have a porous border on the south. There's a reason for that. There's the American hospitality industry, our building industry, our ag industry. Without that workforce, they suffer. And in the end, we suffer. So it's like we can't have it both ways. We can't, like when we have a water rally because there's not enough water in the valley, and they bring their workers, they talk about these brave workers and these other great families, and we got to make sure we have their jobs. And the next day when they get sick, they're illegal aliens. There's these people coming out of spaceships or something that we don't know who they are. We can't have it both ways. So I think there's a lot of education, but a lot of standing tall, that we have to do. And I'll go just a little off base, but this past weekend, since I left office last year, I have not read one local newspaper, nor have I turned on one local news station or talk show. It's been a cleansing for me. It's a part. It's a part of my process of retooling and saying, okay, where do I go from here? Because a lot of times when you're in politics, you think, oh my God, me and Hugo passed something, and we're now providing health care for kids, and the whole world just saw what I did. No, everybody's busy, right? Going to jobs, raising kids, taking care of business. 90% of the people don't pay attention to what we do. So that's when I step back to the last few months and I've looked out, I say, well, why didn't they see what I did? Or why don't they? Well, now I understand, because people are busy. So it just tells me I have to think of different ways on how we educate and how we get the word out. So that's part of it there. And I think, and I have to admit, other than watching Rachel Maddow, every night, the other day I bit somebody in town. posted something on Facebook and said, you know, he owns a sushi restaurant, and then he had 4 bad tables that were bad tippers, and I guess they happened to be Hispanic. Well, he should have left it there and dealt with that, but instead he posted on Facebook and said, you know, worst tippers in the world, Hispanics, so I'm going to build a wall around my restaurant. And about 10 people sent me this post, and I'm on vacation, and I said, okay, Henry, leave it alone, leave it alone, leave it alone. Well, finally I said, no, this is not right. So, but I use social media, I'm sure like a lot of you do, at least politically, very effectively in terms of putting out my issues, because I want to know what you think. You know, because it'll help me shape public policy. So I put it out there. But what I did is I used their term that they have tried to ingrain in us for the past year, and what is that? The wall. You know, the symbolism of the wall. So my post was basically, this guy wants a wall, why don't we give him an economic wall? And we'll build one around his restaurant. Oh my God, this thing has gone viral. I mean, just this morning when I came in, I didn't know I had friends in St. Louis, but they said some very mean things. But that's okay. You know, I think that's part of the process. You know, we're in really tough and changing times, different times. And part of all of this, what we're doing, is keeping the progress that we've made, but 1, not losing ground, but 2, gaining ground. And again, how do we do that? You know, we have to stay engaged, not just in what we're doing, but politically, but also holding people to account for what they're doing. Because we know when, you know, history around this world has shown that when we are silent, before you know it, you're like, what happened? And I don't need to tell you, go down all the examples. So we have to just be very vigilant in terms of, you know, keeping the ground that we've had, but also make sure we don't lose it. So.
You're bringing up very important issues, and I think echoing some of what each other is saying. I want to stay for a minute with this subject of reaching people through social media and through other ways, and the issues of charting. At Zuckerberg San Francisco General, we had a community meeting soon after it became clear that there would be changes in immigration policies. And as a result, the Department of Public Health started a "You Are Safe Here" campaign, in which posters were posted, you know, throughout the hospital and its affiliated clinics. But more importantly, a postcard went out to every patient, a postcard saying the healthcare system was safe, went to every parent who has a child in the San Francisco Unified System, and all of the 300 community-based organizations that a contract with the city services received materials to distribute with the "You Are Safe Here" campaign. A huge issue for the clinicians, particularly the pediatricians, was that we have been taught that the social history matters. That's why we work at a public hospital, and to take social histories and document the social history. And the issue of whether or not charts are safe and whether or not we should be continuing to ask people about their documentation status came up very much to the fore as of particular worry to our pediatric residents and others. And the advice that we are giving people is to ask only when you have a need to know, meaning when it completely affects the medical care, not as part of the general thing, and not to chart. And that is a different advice than we had given previously, because medical records are protected. But it is actually correct that obviously that they can be subpoenaed as part of that. That said, by the time people are subpoenaing medical records, that's the least of their worries. So these are some of the things that at least we have been putting into place. One of the questions that you all touched on are the importance of community organizations and the linkage of community organizations to the healthcare services. And I heard about with a lot of enthusiasm about the standardization of asking questions about social determinants of health in a systematic way. And some clinics are now doing that, for example, asking questions about food security or asking questions about logistics and travel. In this climate of fear, what we have found is that many hospitals are required now to ask questions about race, ethnicity, and preferred language in order to get a prime dollars that is for hospital and healthcare systems that receive federal funding. That is a new requirement. What we're finding is that there has been, in many places, pushback from the staff that they do not want to ask those questions because they are worried that those questions will now be turned around to possibly identify undocumented immigrants. And I'm wondering whether you have perceived this or whether or not this has come up as a question. I'm also wondering about how in your systems you advocate, or in the work that you're doing, how do you advocate for relationships between community organizations and health systems? Stay in the same order. Yeah, we can mix it up too.
That's a great introduction, Alicia. And I would say, though, that I disagree with it a little bit, in that I have always throughout my career felt that immigrants' legal status is very important for the medical practitioner to know about, specifically for this very reason, in terms of what kind of social supports, services, benefits, et cetera, they might be eligible for. If you don't know the legal status, you have nowhere to start. And I agree with you entirely that you shouldn't be writing it down anymore. You know, I used to put it in the chart years ago when I didn't think it was such a big deal, but starting in 1998, I realized you can't do that anymore. So I think it is very important to people to know people's status in this country, but you can only do that if you have a relationship with the community already, where your reputation is known that you're not going to pose a threat to that family or that person or that child in my case. You know, and I've been around long enough at this point with the gray and the beard here that I have that reputation in the community. For example, in Cambridge, a lot of my patients were undocumented Brazilians. And I didn't discover until I was leaving and saying goodbye to people that, in fact, I had become the go-to pediatrician for this large evangelical Brazilian church in one of the communities that we served. And so they all knew me and were reassured to come to me, and I could ask them these questions in a way that wasn't threatening. So I think it is very important to ask, but it's also then having those connections with the community that really becomes critical for our capacity to provide services effectively and not have people be frightened from accessing them. Even refugees, you know, the climate around refugees, even though they're here legally with proper documentation and work authorization and everything, you know, it's a pretty scary time to be a Muslim refugee in the United States. You know, and I just was interviewing a young man who was from Iran, who was applying to me for a first job in the U.S., and I tried to delicately, you know, ask him about the circumstances of why he left Iran, and he wouldn't talk about it at all. And I quickly backed off and said, you know, yes, this is a job interview. We don't need to talk about it. You know, I just was trying to be helpful and learn a little about him. But it's that kind of fear that's definitely there, even for people who hold legal status in this country, the uncertainty, not knowing where things are going. And this is just exactly what happened, you know, after 9/11. Refugee resettlement was shut down indefinitely by the Bush administration until what now would be called extreme vetting could be put in place. Of course, you know, certain people don't seem to understand that exists already. But the vetting process to become a refugee is extremely rigorous, and no other migrant to the U.S. has to go through that kind of a process. Yet people are still scared and uncertain about who these people are. They're different from us, and a lot of the refugee populations that come into the U.S. now are much smaller groups. They don't come into large pre-existing communities. And so helping them get established, there was a funding stream from the federal government to create what are called mutual assistance associations, which are small community agencies to support local refugee populations. Helping those, establishing relationships with them, whether it's as a clinician or a public health practitioner, really is critical in creating the relationships that allow people to continue to access care without being scared.
Okay. I'm going to jump right into the relationship piece first and then go backwards. I'll try to remember all of them too. I think for many health centers, all health centers are required to have a patient majority board. And for those health centers who use their patient majority boards well, their patient members are actual advocates within their own communities. But many of APCHO's member centers go beyond the use of the patient community consumer board members. You'll hear more from Julia later on this afternoon, but Asian Health Services has modeled what we call patient leadership councils. And they have it in the largest immigrant groups that they see in their service area. And these leadership councils are representatives of, some of them are predominantly seniors, those that are predominantly seniors in their service area, but some are very diverse in age groups, including youth leadership councils as well. And the health centers have been engaging these leadership councils for over 10 years now. And so when things like the current environment come, the community already have relationships with these council representatives and can utilize these trusted community members as their spokespersons to help them with the outreach in their community. It's the pre-existing relationship, I think, that the doctor here has shared with us, and making very intentional efforts in cultivating that relationship before it's actually needed. But it can also help them in program design and a lot of the cultural competency questions that come up around changes in coverage and how to prioritize which services we should be providing in our community. That's what these councils are most useful for. With regards to the standardization of questions and so forth, I actually don't know all the details and implementation, and our representative from Oregon will be able to go into much more, but we do collect preferred language and race and ethnicity. And last year, we hated doing this, but there was an intentional effort to take out or eliminate the foreign-born question. Initially, a lot of the researchers said we need to have that, particularly for all of our disparities tracking. But given the political circumstances, even before the election, there was already a decision that was made to eliminate the foreign-born question. And many of us who work with this community, or particularly in some of the research work, was going, what are the best proxies that we can then use if we're not going to actually have that particular question? But our folks do feel comfortable tracking the race and ethnicity and preferred language, particularly for their service provisions.
Yeah, I'll hit the how do we help each other? How do we work closer together differently? Because I don't have a lot of the nuts and bolts of what these gentlemen are talking about, but I'll just use an example. Over the holidays, a pretty influential group of and well-respected group of Muslim doctors had a dinner at their home, and they invited me to come. So I did, and it was interesting. They were there with their families, and their question was this: We're doctors. We're all Americans. We're respected in our community. When we get sick and the specialties that were in that room, you'd be humbled. Because, you know, when you're really sick and you go to these guys, you don't really care where they're from or who they are. You want to get well. But what they were saying is they're picking on our kids at school. They're criticizing my wife at the grocery store. You know what the stories are. And their question to me was, what do we do? What are you going to do, Henry? And then, of course, they're serving a meal, and the meal was being served by a Syrian refugee family that had just gone through that 18-month of severe vetting process and was there, and they were a beautiful family, great food. And, you know, and I have to tell you, when I left there, I just felt this weight. You know, it's like, what the heck's going on, you know? So, I mean, we had a great discussion, and what I told him, I guess, is what I'll say here is, you know, one of the biggest challenges that I think that we have is you represent in some way, shape, or form, whether you're the direct care provider or you're the community group trying to give folks access, you represent a population that has no voice. They have no power. And when I bring it back to the context of what I was in for over 20 years in politics, sadly, or right or wrong, a politician makes a decision based on two very easy criteria. It's either what's the best thing for this community or what's the best thing for me. And it's really that simple. And you can tell sitting 10 minutes in any political dais what their bent is. So when we have populations coming into our doors, and I saw it more so towards the end of my political career, was, you know, you can see the calculation. Oh gosh, look at all these people in here. You're all here on trying to motivate me to vote for health care for X. And I look at you, I say, they don't vote. They don't have any money. So why should I care that you're in the room? A lot of folks are doing that. You know, which I hate to beat a dead horse, but it's why it's important who are sitting in those chairs. But how do we help each other? And what I told those doctors is we have to engage in different ways. The community groups that are out here that have the troops on the ground. I mean, you got to hold hands even tighter with these healthcare professionals and make sure to understand that if the issue is, well, do we document? Do we not document? What does it mean? What are the impacts? I mean, we have to hold hands and create a political power so that we can help counter those kind of things. Because there's that force pushing right now against it, and we have to push back. And I'll just close with, and the reason why I gave you that example of this restaurant and this wall, part of my social media is imagery. And I threw their image back at them. I didn't say, hey, just don't eat at that restaurant if you don't like what they said. I said, build an economic wall. And that's what drove people nuts. And it's still to this morning. I mean, it's just the concept that this concept came back to them in a different way. And what they're saying and seeing is whether we're undocumented or refugees or whatever, we have a tremendous amount of economic power. How do we harness that? How do we use that? How do we use that to send messages back to people? Okay? So, I mean, you can kind of see, you're seeing where I'm evolving now as I'm leaving what I've done for the last 40, 50 years and now staying active, but now moving in a different direction, using what I know in a different way. And it's just activism, and if we stay in our silos, healthcare provider, community organization, or community group that represents people, if we stay in silos, they pick us off. We come together, we have strength. And I think that's where we go.
I'd like to take a few questions.
Well, we're going to have a whole discussion. We're not going to take your question. You can. So how much longer?
5 minutes? 8 minutes.
Can I? To just expand on the previous speaker, as I shared with you in my introduction, APCHO's member organizations serve over 750,000 patients each year. And we do our advocacy work, and we do visit our legislators, and for many years we would hear, I know you do important work, but your people don't vote. And so we started working on that about 5 years ago, and for the last 3 years we've had an active civic engagement campaigns in many of our health centers, and we still have early evaluation returns, but in some of our early returns, we have a 20 to 40% increase in voter turnout in the service areas where we had been involved in the last 3 years. We're really looking forward to being able to get that type of evaluation information from the rest of our service areas. It highlights a particular point that many policymakers don't know about the Asian Pacific Islander community. Yes, we do have our undocumented, but we also have the highest percentage of lawfully permanent residents in this country. And so we have to both remind our policymakers that yes, there are undocumented Asians and Pacific Islanders, Asian Americans and Asians in this country, but we also have a very large citizenship or lawfully permanent resident populations that are eligible to vote and has just not been engaged by any political party, and so it's been very intentional on our part as a national advocacy organization to get civic engagement more integrated in our local support structures.
I was thinking that I would try to just bring it back a little bit to health literacy, because we've gone into sort of a wide-ranging discussion about legal status and policy. And, you know, for me, coming out of our work with the Somali community in Massachusetts, I already mentioned that if we learned one thing, it's that the relationships between culture and English proficiency and health literacy were very complex. And as we looked at different outcome variables in our study, which was focused on oral health, but we had a number of different outcomes as well. There were different relationships that literacy sometimes played a role, sometimes it didn't, sometimes it had no relationship whatsoever, it just didn't matter. And one of the things that came out of it, as I've already mentioned, was this theme of social capital and community supports really being critical. And so to the extent that literacy matters, that's always going to be an undercurrent to it. So there are ways to get around low health literacy when working with communities or individual patients. And the Somalis are a terrific example that their health status is pretty good, especially with respect to their oral health status. And there's reasons behind that, and some of it comes from their Islamic faith, which we're now as a country kind of holding against them. But in fact, that's a strength of their community and their health status. And so understanding these things and these undercurrents, that there are different factors to what goes into the person and the community that can support people without having the literacy skills there, really becomes an important factor in effectively engaging and providing care to those communities.
Yeah, after hearing that last comment, it reminded me of some of our efforts and challenges with enrollment for ACA. You know, as I shared in the beginning, again, we worked with about 72 community-based organizations and FQHCs in 22 different states. And yes, we did see the benefit of having community navigators. However, many of our community-based organizations actually did not receive funding to provide community navigation, enrollment navigation. There were some trainings that were available, but in most instances, there was that heavy dependence on the helpline, which was very unpractical in almost all of our sites and states, as well as the computer enrollment efforts. I just have to share with you, Massachusetts is perhaps our state with the lowest uninsured rate. And one of our health centers there tells me time and time again, yes, our state is very progressive. We have multilingual computer enrollment forms, but I have to hire staff to help, 35,000 people enroll every year because it's not in Chinese or Vietnamese. And so this is staff who are not reimbursed by anybody, but he has to do that for 35,000 people every year because of his commitment to making sure that his patients are continuously covered. The materials that were provided, particularly by the feds in terms of the language, the dictionary for ACA, many of our community partners found them to be too complex and really tried to simplify them. And so as a community network, we actually developed a glossary of the 100 most frequently used terms and concepts, and had the community panels develop these. And I'm not sure if it's in 8 or 10 different languages. You have to correct me, Ian. But they're all made available online. We tried to get the feds to endorse them, but they said that they couldn't accept the terms that the community find because they were required by the federal terms that were already approved.
So thank you. I want to turn it over to Dr. Rossoff to talk about the questions, but I want to say thank you and reinforce for the panel. And reinforce for the IOM roundtable members some of the themes that we heard around the different definitions of legal status, the strong relationship with community groups, the larger political context of fear and documentation and ask the questions, don't ask the questions, and throughout the issues of the broader political context, which I think you so excellently brought out. So let's have some questions, because I think that you've done a fantastic job of framing the morning for us.
Thank you very much, Alicia, and thank you once again to the panel members, Paul, Jeffrey, and Henry. To think we have representation from the East Coast to the West Coast for topics that are really national, if not international, really is important for us today. The comments I heard really remind me of a statement that Martin Luther King once made that said, if I cannot do great things, I can do small things in a great way. And so this is exactly what we heard today, and I think that's just too wonderful. So thank you all, really much appreciated. We now have about 30 minutes to open this up to questions. We'll start with the roundtable members, and then if time allows, we'll go to the others. But I really want to hear from people outside the roundtable, because this is such a diverse audience. I really want to hear comments from others. So I will cut short the roundtable members and go to the public if there are questions from the public. But we will start with the roundtable, so we'll go from there. Ruth?